to use the drug-coated balloon. The number one indication is to treat in-stent restenosis when predilatation results are optimal. To use a drug-coated balloon. Optimal lesion preparation, mainly with non-compliant balloon sized according to angiography. I like to state that the introduction of drug-coated balloon makes us to redefine the way to perform PCI.
Welcome to the International Interventional Cardiology channel. Our channel coordinator, Professor Marco Valgemigli, has the honor of presenting Professor Colombo to share his expert opinion about the late-breaking data on drug-coated balloons and their revolutionary impact on treating coronary artery disease. As we all know, Professor Colombo is a world master in the field of interventional cardiology. We are sure you will find his insights useful to your practice in many ways.
This presentation is about usage of a drug-coated balloon in coronary artery disease, state-of-the-art in 2024. I would like to state that I have no conflict to disclose regarding this presentation. I would like to introduce this presentation with this recent publication by Dr. Tarantini in the European Heart Journal 2024. This is not related to drug-coated balloon, but shows the advantage of not having a permanent implant. You see on the left the OCT images after implantation of a bioresorbable scaffold. In the middle, the 5 years follow-up, and on the far right, the 10 years follow-up. Not only on the angiography, but more clearly on the OCT images, you see the advantage of the absence of a caging, allowing positive remodeling. This is a unique feature of a bioresorbable scaffold and possibly of the drug-coated balloon, able to deliver to the vessel wall a antiproliferative medication without caging the vessel. Let me start with this important statement: when to use the drug-coated balloon. The number one indication is to treat in-stent restenosis when predilatation results are optimal. It is very important to highlight when predilatation results are optimal, otherwise you implant another stent. In small vessel PCI, there are plenty of studies randomized supporting this statement. To simplify the procedure, this is something new, and I will go over this aspect later on. To avoid full metal jacket, especially on the left anterior descending, and we have recently published a study highlighting this advantage. And in high-risk bleeding patients, to avoid excessive stenting with the need for prolonged dual antiplatelet therapy. To use a drug-coated balloon. Optimal lesion preparation, mainly with non-compliant balloon sized according to angiography. Imaging to select specific device to treat calcium and to evaluate residual lumen after dilatation. Do not use imaging to select balloon size. Try to dissect the plaque and not the media or the adventitia. For this reason, high-pressure non-compliant balloon or cutting balloons should be undersized. When treating diffuse disease, angiographic sizing is not reliable. Therefore, IVUS should be utilized, but remember to undersize at least 1 millimeter when measuring media to media. Use cutting scoring balloon before DCB treatment for in-stent restenosis. And remember that the drug-coated balloons are just meant to deliver the medication and not to perform lesion dilatation. The ISA Desire 4 trial is a very important study highlighting the value of cutting or angiosculpt any scoring balloon treatment before DCB versus conventional POBA. You see the diameter stenosis at 6 months went down from 40% to 35% in this randomized study when scoring balloon was applied before drug-coated balloon. The same advantage is when you look at the binary stenosis decreasing from 32 to 18.5%. Therefore, using scoring balloon before DCB improves the result of in-stent restenosis treatment, and in my opinion, this approach should be routine. We just discussed the value of drug-coated balloon for small vessels, and this indication is supported by randomized studies. We published in 2012 the Bello study with an advantage in late loss compared to paclitaxel eluting stent. This statement has limitation because late loss is dependent upon acute gain, which is lower with DCB. Nevertheless, binary stenosis was fine for DCB 10% compared to 15% for paclitaxel eluting stents. The 2 years result published in 2015 confirm the advantage of DCB with a lower MACE rate compared to paclitaxel eluting stents at 3 years. Similar results were recently published by the large randomized study Basket Small 2 published in Lancet. In addition to the prior 2 indications, which is in-stent restenosis and small vessels, I added another indication to simplify the procedure. You see a long diffuse disease in the circumflex following predilatation with a 2.5 non-compliant balloon. We have a good result, and the 1-year follow-up maintains such a good lumen. Stent implantation at the ostium of the circumflex will cause a carina shift with a subsequent need to dilate the LAD. In addition, circumflex access may not be easy. Therefore, the use of drug-coated balloon in this setting simplifies the procedure. I like to show this left anterior descending disease with a long proximal, mid and distal disease of the LAD, most of the time requiring long stents. This case was approached with a short drug-eluting stent proximally and a too long drug-coated balloon. This strategy avoids full metal jacket, especially on the left anterior descending. This slide shows the 1-year follow-up of the prior case with good preservation of the lumen in the mid and distal left anterior descending, which was treated only with drug-coated balloons. This approach was recently supported by this paper by our group, first author Mauro Gitto, comparing drug-coated balloon angioplasty for de novo lesion on the left anterior descending with a propensity score matched group treated with long stents. You see that following matching, the target lesion revascularization is in favor of the approach utilizing a drug-coated balloon with focus stenting rather than long stents. I really believe that in this area the use of this hybrid strategy should be very much implemented. Our last important indication is in high bleeding risk patient to avoid excessive stenting. This is an 88-year-old gentleman with atrial fibrillation, long diffuse disease of the LAD, same for the right coronary artery. This patient was treated with rotablation and 3 drug-coated balloons on the left anterior descending, cutting balloon, and 3 drug-coated balloons on the right coronary artery with no need for stenting at all. This slide shows the immediate result with good lumen achievement in both vessels with no need for stenting. The 6 months follow-up support the strategy adopted with a good lumen preservation confirmed by 0.91 DFR obtained on the LAD. In the lower panel, you see the diffuse disease of the LAD at the baseline. To conclude, I like to state that the introduction of drug-coated balloon makes us to redefine the way to perform PCI. This is a new view in search of evidence, but evidence is being built, and some of the statements are not just hypothesis generating, because DCB are now as deliverable as drug-eluting stent. DCB are as safe as drug-eluting stent, plenty of data supporting such a statement. DCB will close less side branches than drug-eluting stent, no specific study but quite intuitively accepted. DCB allow positive vessel remodeling, and this has been proven in various studies. DCB preserve vasoreactivity, and DCB do not always need dual antiplatelet therapy. We need more data, but I believe this statement will be supported by data very soon. Thank you very much for your attention.
Dear colleagues, if you have any interesting or even controversial comments, please feel free to post them in the comment box below. I will provide feedbacks, and the International Interventional Cardiology Channel Secretariat will post them on my behalf.
Please take 10 seconds to learn how you can be more than just a spectator at P2P. Right now, tens of thousands of healthcare professionals are actually watching this video. You may take this opportunity to post your own cases, best practices, and research data in the comment box underneath the video. So, don't miss out on this chance to make your work known to global peers.
If you have any captivating insights that you would like to share with your peers, please email your thoughts to kol@p2pmd.net. Here at P2P, we welcome collaboration with the brightest minds on the planet.